I'm Meryl Chertoff, Executive Director of the Aspen Institute's Justice and Society program. We've been really pleased to partner with the Robert Wood Johnson Foundation on the Excellence in State Public Health Law program, a one-year, team-based state public health law policy leadership program. We shared a vision, which is that when we build relationships between the state public health agency and members of the legislative branch and governor's staff, we'll get better results for public health than any of these actors working on their own.
And public health is usually the agency of no. We're usually locked into the formal communication of public hearings, maybe some side meetings with legislators. It actually surprised us that they were very interested in being full and vigorous participants and engaging with legislators in particular on a different level outside of the song and dance of the legislative session. Really, like I said, has given us this project some visibility and a lot more resiliency going forward.
It was really important who was on the teams. Our team leaders were the state health officials, but we also wanted legislators in the room. Both members who had championed on health issues before, but also recently elected officials who came in with a fresh perspective.
I've always thought that the biggest public health interventions are really public policy interventions. And working with policymakers along with public health professionals is a way to get at those. And this project was taking specific programs or initiatives in different states and then looking at the public health perspective and the policy perspective from those different states has really been quite beneficial to me and our team.
Truly, I think the biggest advantage has been the relationship building. Being able to very quickly build relationships with the governor's office, with our elected officials on the health care committees in both the House and the Senate, and their staffers, really was about how do each of us in our roles be able to come around a specific focus of supporting breastfeeding, and in this case, baby-friendly hospitals, and move that agenda forward. So the relationship piece was just remarkable.
For the first few months, a lot of what went on was building of relationships and refinement of the projects. And the teams had to strike a balance between idealism and what was feasible given the realities in their states. But when the teams came together in subsequent retreats, they started to cross-pollinate ideas, not only sharing what they knew as expert, but also comparing experiences across states.
I think it was a good sounding board for us to be able to talk to other states. A lot of the states are working on things that we've already done in Arkansas, so it gave us a chance to provide them information. But I also think that we kind of learned what the roles of all the team members were by seeing other states in action.
When we stopped and thought about it, we realized that if we look at the process and we, if possible, by the end of the program come up with a model, then maybe we would have something by the end of this that would not only be useful in Virginia, but could be instructive for other states who were participating in the program.
The projects were really diverse. Hawaii worked on oral health for Medicaid-eligible kids. Arkansas and Virginia were interested in joint use agreements and access to sports. Rhode Island laid the groundwork for its innovative concept of neighborhood health stations. Minnesota looked at adult binge drinking. Washington at encouraging breastfeeding. Louisiana at healthy eating. And Connecticut at the relationship of local and state public health agencies. The cohort retreats really helped because team members would meet and they would get excited and not think, oh, I'm a legislator or I represent the governor, but how do I solve this problem?
Oftentimes, a governor and governor's office will create a new initiative and then take it to the legislature, and the legislature will reject it because it wasn't their idea, it's too far cooked, they want their stamp of approval on it, and so they'll change it. So here they've got them both owning it from the get-go, working together, along with some other folks, and then reaching out to stakeholders. And I think that that multidisciplinary way of approaching public policy is the only way we're going to get anything done in the future.
And that spirit also energized them when they went home and met with stakeholders.
The way this has been set up has enabled us to really talk about our mutual interests just by saying, here's my idea. What do you think of it? What are you doing to work on this already? And where are the overlaps that we didn't even realize?
And we provided technical assistance money. The teams used it in very creative ways, funding meetings and creating some terrific video products.
It's amazing how much you can leverage small amounts of dollars and do some big projects.
And there were lessons for everyone. The political branches learned more about public health priorities and the importance of data. And the public health people learned that while your policies are of course data-driven, sometimes you can be most persuasive when you wrap that data into a narrative. Not all of the projects achieved their goals. Sometimes the political realities were too much. And that taught that you really need to find your constituencies, and they can be hiding in plain sight sometimes. And there are some best practices that can be used over and over again to build consensus and move policy. What we learned is that the states still are powerful drivers of policy in public health, but that it works best when we don't think in terms of our institutional roles, but on advancing the common good.